All right, let's get started. Welcome, everyone. Thank you so much for taking the time and joining us today for our POCUS Bites webinar. My name is Daria, and I will be your webinar host today. The webinar is now beginning. All lines have been muted. Please use the Q&A box for any questions or the chat box for comments you have throughout the webinar. Today's topic is role of ultrasound in diagnoses of ovarian cysts, and our speaker is Dr. Ahmed Galal. Dr. Galal is distinguished professor and a consultant in reproductive medicine and infertility at Alexandria University. He brings decades of expertise backed up by global training and prestigious fellowships. Welcome, Dr. Galal. We're so excited to have you with us today, and thank you for taking the time to present.
Thank you so much for this nice introduction, and thank you for all the attendance. I hope you are very fruitful and very interesting webinars, and please feel free to share your thoughts, your question on the Q&A section. Would you like me to present?
Yes, go ahead and share your screen.
Okay, thank you so much. Okay. So good morning, good evening, good afternoon for everyone according to your place all over the earth. So the presentation today will be on the role of ultrasonography in the management of adnexal mass, a very important topic, and how we can assess the ovarian cyst, and then we have some entity about the adnexia itself. So the role of ultrasound was mentioned in many aspects of the guidelines worldwide, and if you can see here in the Europe and as well as in the UK, in the United States of America, still we have many of the guidelines supporting the role of ultrasound and saying that, next please, and saying that a transvaginal pelvic ultrasound is the single most effective way of evaluating ovarian cyst in the postmenopausal woman. And in another statement, it is the most effective way of assessing the ovarian cyst in even the menstruating woman and young age group. Next, please. Next. So what is the adnexia firstly, and what is the ovary itself? So the adnexia is this part lateral to the uterus, the ovary, the tube, and the adjacent structure to it, like the para-ovarian and so on. So this is the area of the adnexia. So to make it very simple, it's the ovary and the fallopian tube as well. Next, please. Many factors you should determine with that one. Firstly, you can assess very well the size. If you see here, this is a laparoscopic picture. The size of the right ovary is different from the size of the left ovary here. So the size is very important to be taken into consideration. Next. The position as well is very important. It is the lateral position of it. It's adjacent to the uterus. It's anterior to the uterus, posterior. It is adherent or not. This is very, very important. It can be assessed very well by the ultrasound as well. Next, please. And combining the size and position in this slide, and the next slide, please, you can see a lot of information. You can get a lot of information in this part, so you can get a lot of diagnostic criteria. So this is how you can imagine, firstly, where is the adnexia, where is the ovary, where is the tube, and how you can assess its relation to the other one. Next, please. Then you should be aware of the nearby structure, which is very important because you are not alone in the adnexia and it's not alone in the pelvis. So we have a nearby structure. You should be aware of this nearby structure. So don't overdiagnose or underdiagnose any mass you are seeing. Next, please. Another picture of nearby structure. Next. The third point, which is what is the mimics of the normal ovary, is to have all of us on the same ground from the start. So the mimics of the normal ovary will be the congested veins in the broad ligaments, small subserosal myoma, and the psoas muscle by transabdominal sonography. The first two is very important. If we can see the next slide, you can see here how the pelvic congestion syndrome and how the congested veins in the pelvis will appear. If you find this one on the left side, you can see here that there is a lot of vacuolations, a lot of spaces that can mimic some of the structures from the adnexia itself. But if you put a color Doppler in it, you will find it a pelvic congestion, and you will find a lot of veins congested with the blood. And this is a picture on the laparoscopy. So it's very important to have this information in your brain firstly to start with. Then next, please. The other is a subserosal myoma. So in subserosal myoma, it can resemble very much the adnexial masses if you don't differentiate between both of them. Next, please. Some scanning tips, some scanning tips in this area. Number one, identify the ovary by itself, which is a major point of reference for the adnexal structure. So try to identify the ovary itself, not to identify the follicle, and from the follicle you identify the ovary. No, you identify the ovary. The ovaries is usually situated anterior to the internal iliac vessel, which serves as a landmark for their identification. Because if you identify the ovary by the follicle, you will have a problem in the ovary in the postmenopausal woman, as an example, or a woman with poor ovarian reserve or premature ovarian failure. So you will have a problem in identification. So identify the ovary itself, which with its size, shape, contour, echogenicity, all of that should be assessed very well in relation to their position as well to the uterus. Next, please. Next, please. If you can see here from the picture on the right side and the picture on the left side, you can see here the ovary with differences in the size itself, at the same time in differences in the size of the follicle inside. So very important to have all the delineation outside, all the contour of the ovary. Next. And then it's important also, before going to any pathology, to have the ultrasound of the ovary after ovulation. So it's very important to have the timing of the cycle itself, which is a follicular or a mid-luteal, or at the time of the ovulation itself. We will see in the next two slides how this can be affected. So next, please. So on the left side here, you will see that this ovary containing some small follicle, and this is a resting follicle, or this is a follicle in the very early phases of the follicular phase, and you are suspected to find the endometrium here as it is. It may be menstruating or early in the follicular phase. So it's very important. The other one on the right side, you have here a one follicle, more or less reaching the maturity of the follicle, more reaching a full size. So you will have here the implementation of that on the endometrium itself. So you will have the endometrium, it's a full maturated triple line endometrium. So this is another point. And I will give you one of the stories here that I was one time asked from one of my colleagues, actually as a consultation, that he did some of the ovulation induction for a woman, and he see only one ovary for her, and this one ovary containing small follicle like on the left side here, but he see after a while, and then he induced the woman when one of the small follicle reaches the maturity, but he didn't find the other ovary itself, and he assumed that the other ovary have a small follicle. That's why he didn't see it. By the end, this patient came into ovarian hyperstimulation syndrome, in which the responses was very, very high, and at the same time, she was admitted to the hospital and then ICU admissions and so on. The problem here, when I asked him that, did you see the other ovary very well? He said no. But so the other question, did you see the endometrium very well? He said yes, the endometrium was a triple line, although the follicle was small. So these are contradictory issues. So it's very important, if you see the triple line of the endometrium, be sure that you already see both ovaries very well with the follicle inside them. So this is another point, very, very important. Next, please. Then you will have like the corpus luteum, and this is the effect of the endometrium itself with the homogeneity and the progesterone effect. And on the right side, you will have here if the corpus luteum of pregnancy with its hemorrhagic picture here, and then you will have the pregnancy inside the uterus, inside the uterine cavity itself. Next, please. So For any adnexal cyst or ovarian cyst, you will have to answer this question. Is it a functional cyst or a pathological cyst? Is it ovarian or it is not ovarian cyst? It's a tubal or paratubal or any nearby structure. Next, please. And here come the ultimate goal of the ultrasonography in this adnexal mass. And the ultimate goal is to determine whether the mass is almost certainly benign, whether the mass the mass has some reasonable chances of being a malignancy. This is the main whole or the main entity how you can diagnose it. So what is important is that if this is a benign mass or it is a malignant mass, what is the higher chances for it to go benign or malignancy, because the management will be so much different between both of them. Many classification systems were developed actually for detecting this goal, starting by the IOTA, the RMI, the ADNEX, and the O-RADS. All of these classification system was developed. So let us go in depth with this classification system and see how we can implement it in our daily practice. Next, please. Next. The first one here, next. Yeah, the first one here started, no, the previous one. Yeah, started in 2000 with the terms and definition and the measurement for the IOTA system, which is the International Ovarian Tumor Analysis. And this group next, saying that we can classify the masses according to the simple ultrasound rule. This simple ultrasound rule, next, please. Yeah, this containing two criteria, which is M or B. M coming from malignancy, B coming from a benign. So if it is malignancy, we have 5 criteria. If it is a benign, we have 5 criteria. If it is irregular solid tumor, presence of ascites, at least 4 papillary structure, irregular multilocular solid tumor with large diameter more than 100 millimeters, or a very strong blood flow, which is a color flow score 4, this is considered M. On the other side, if we have B1, which is unilocular, B2, which is a presence of solid component less than 7 millimeters, acoustic shadowing, smooth multilocular tumor less than 100 millimeter or 10 centimeter, no blood flow or a very minimal blood flow. So this is a criteria. And saying that if we have one M criteria without the presence of B criteria, it is considered malignancy. If we have one B criteria without M criteria, it is considered benign lesion. This is the simplest rule for the ultrasound. So if you are like a general practitioner, or if we are like in a remote area, and this is a very simple way to diagnose. Next, please. Next, please. And this is the simple rule, the same idea, and this is the same picture. You can taking this picture in your mind, and then whenever you find this picture, this is the feature of malignancy for the masses. The next slide will be the feature. Yeah, these are, next please. This is the nature of the benign lesion. You can see here the blood flow here is very minimal, the size itself, the solid areas, projections, and so on. So this is number one, the simple IOTA system classification. Next, please. Next, please. Yes, and this was more updated on 2013 and saying that it have a high sensitivity specificity. However, still we have 12% false pregnancy rates, false rates. So the other one is the development of the ADNEX model system. The ADNEX, it's abbreviation of Assessment of Different Neoplasia in the Adnexia. And this containing 9 criteria, 6 ultrasound variable and 3 clinical variable. 3 clinical variable, the age of the patient, serum CA125, and type of the center. On the other hand, 6 ultrasound variable, the maximum diameter of the lesion, the proportion of the solid tumor, more than 10 centimeter loculi, number of papillary projection, acoustic shadowing, and ascites. But here it's very important that we didn't find any Doppler assessment in this assessment system or ADNEX model assessment. How we can get it? Next, please. You can go online and you can type IOTA adnex model, and you will find the IOTA adnex model like that way. The ages, the 9 criteria we said about, and just you will enter the value, or you will choose from the drop menu what you are taking on, and then you can calculate. The next slide, please. And this on the calculation will give you the chances of being a benign, of being a malignancy, of being a borderline, and you can actually discuss with the woman at that stage what is the possibility of malignancy, and so what is your next step for the management very well. So this is the adnex system. Next, please. Although this productivity of the IOTA simple rule and the adnex model system is high and it's common usage in the Europe per se, the other one, it is not the same criteria maybe in the United States and Canada, and there is other classification developed. But one of the hallmark of the classification, which is a simple one, and we will put some stress on it today. Next, please. Is that of the O-RADS system, because all the previous studies didn't include the standardization terminology and definitions for the lesion, didn't recommend the management for high-risk lesion, didn't provide objective criteria for all the lesions. So, next, please. The development of O-RADS was one of the new areas that was developed in 2020 after the reporting the tool on 2018. Next, please. The principal goal for the O-RADS was standardization of the basic sonographic definition to limit the variability in reporting the language. So I am saying the same language like you in the Africa, like you in the USA, like you in the Europe, and so on. Establishing a risk stratification algorithm, very important, and establishing the guidelines for the management of these lesions. Let us start with how this system put these 3 criteria very well. The first one, next, please. We have here the O-RADS system, the major categories. Next, one by one. Yeah, this one is the unilocular lesion. So it's only one locule without any solid component. If you go next, so this is a unilocular with a solid component inside. The third one is multilocular with no solid content inside, of course, and then multilocular with a solid component inside, and then the solid masses. So we have 4 criteria of the ovarian lesions here, or the ovarian cyst, and the other one with the solid one. So this is the picture that we can see in whatever the lesions of the ovarian mass. So we have one of these 5 criteria. Then we can go more in depth for the first one. So if we have like a unilocular, that may be unilocular only and containing clear fluid inside, there is nothing inside. Maybe like in B here, we have a septation, if you can see, like a septum inside, or maybe unilocular, but still we have a solid component or a papillary projection inside, maybe some punctuations and hemorrhage inside, or maybe more hemorrhage and more reticular formations and the blood clot formations, or it may be like acoustic shadowing. So this is the hallmark only for the unilocular cystic lesion with no solid component. Then next, please. The color Doppler scoring, we put the color flow, the color Doppler, and then we can have no color flow, no blood flow is detected, or a very minimal. The minimal one is number P, so this is considered color score 2, or then we have color score 3, where there is a moderate flow, or there is a lot of blood inside, so this is color stage 4. Then next, please. So this is how, firstly, we standardize the definitions we say. So we have unilocular, multilocular with a solid component inside, or no, or it is completely solid. And for the unilocular, septation or not punctuation, the reticular formation, so on. Then we have to establishing a risk stratification algorithm. How is this done? Firstly, by, next please. This is how the stratification categories saying it's a physiological or a classic benign lesion or a lesion with non-classic one, which may be solid or cystic, which is our topic here. So this is a big picture. This is a whole pathology that you can encounter. How we can hold all of that in our mind, these are very simple. In the next slide, we can see. Next, please. So we have 5 categories of the O-RADS. O-RADS 1 means this is a physiological category. It's a normal for the premenstrual ovary. O-RADS 2, this is almost certainly benign category. So you can counsel the female that you don't have a high risk of malignancy. You have only 1% or less than 1% of malignancy for the O-RADS 2. O-RADS 3 means there is a low risk of malignancy from 1 to 10%. O-RADS 4 means the lesion with intermediate risk of malignancy up to 50%. And then the O-RADS 5, next please. Oh, no, next. Yeah, O-RADS 5, lesion with high risk of malignancy, more than 50% of the chances, or the chances of getting malignancy more than 50%. How we can classify these O-RADS, we will see. Next, please. This is the third point for the principal goals of the O-RADS developing system. So establishing the guideline for the management. Let us start by O-RADS 1. O-RADS 1 means it's a normal ovary with no likelihood of malignancy, very negligible, because it's a follicle or it's a corpus luteum. If it is the follicle, this is the definition. It is unilocular. So no. It's a unilocular, as we can see here. It's a unilocular. At the same time, it's anechoic. There's nothing inside, and less than 3 centimeters in diameter. So this is considered the follicle. This is a physiological one. The corpus luteum, you can see here with the corpus luteum how you can assess this corpus luteum by many of the picture. If you can see here, it may be reticular formations, it may be punctuations, like in the second row, it may be the blood flow from the periphery outside. So it's very important to have this picture very clear in your mind. So this is O-RADS 1. You can, next please. Then for the O-RADS 2, this is almost certainly benign lesion with less than 1% of likelihood of malignancy. And this containing the simple cyst. Simple cyst means from 3 centimeter to less than 10 centimeter in the premenstrual woman and less than 10 centimeter in the postmenopausal woman. So to submit it, it's a less than 10 centimeter cyst in premenopausal or a postmenopausal woman. Usually it's a unilocular cyst, as we can see here. So this is a simple cyst. The other one is the unilocular cyst. It's a non-simple, but still it's less than 10 centimeter. So it may have like some punctuation inside, like some hemorrhage inside, maybe some septation. All of that is still, it's a simple cyst because it is less than 10 centimeter. This is very important. The contour is smooth, but may have some septation or some punctuation inside. Next, please. The typical hemorrhagic cyst, whatever the cause of hemorrhage, it may be simple cyst, but hemorrhage inside, still to be classified in O-RADS 2, it should be less than 10 centimeter. So remember all the time that less than 10 centimeter is usually considered a simple cyst, whatever it's complicated by some hemorrhage or some septation inside. Then the typical dermoid less than 10 centimeter is still O-RADS 2. And the typical endometrioma less than 10 centimeter is O-RADS 2. So all this lesion is a benign lesion with a very, very low chance of getting malignancy. Next, please. Simple para-ovarian cyst, if you go out, and typical hydrosalpinx, typical peritoneal inclusion cyst, all of that consider O-RADS 2 because usually they are benign lesions. Next, please. Then we go to the low risk group, but increasing the risk of malignancy more or less. If we can see here, the first entity that may alarm us that there is increasing chances of malignancy will be if it is a unilocular cyst but more than 10 centimeters. So increasing the size is one of the simplest sign of that we may have increasing a chance. So simple cyst or non-simple cyst more than 10 centimeter will be one criteria for the intermediate risk or the low to intermediate risk. The unilocular cyst with irregular inner wall of any size, irregularity means we are away from the benign, we are more or less go to some malignancy, although it's less than 10%, but still we have a likelihood of malignancy. Next, please. And then multilocular cyst with a smooth inner contour less than 10 centimeter with 1 to 3 maximally of the color Doppler. This is considered also a low risk group or ORADS 3. Solid component more than 80% of the cyst with a smooth contour of any size with a color score 1, so or there is no flow. This is also considered of a low risk group, so it's usually ORADS 3. Next, please. Then we go by more orange one. It is the ORADS 4, and here we will start the likelihood of malignancy to be increased, reaching up to 40 to 50%. So multilocular cyst with more than 10 centimeter with color flow 1 to 3 is a one entity. Multilocular with a smooth inner wall, any size with a color flow 4. So if you can see here that increasing the color flow will increase the likelihood of malignancy, as we can see here. At the same time, increasing the size with the multilocular will increase the stage of the ORADS classification. Multilocular with irregular inner wall and irregular septation is another feature of them. So irregularity, higher vascularity, or increasing the size are three main determinants of going to malignancy rather than going to benign lesions. Next, please. If it is a unilocular cyst, but have some solid components with no papillary projection of any size or any color, it's ORADS 4. If unilocular with 1 to 3 papillary projection of any size or any color, still it's ORADS 4. So you have a malignant chance of 10 to 50%. Multilocular with some solid component. So this is a fourth feature, the presence of solid component, especially if it's combined with increasing size, with increasing color flow, or with increasing the size of the lesion itself. Then, next please. And this is a solid component more than 80% with a smooth contour, but with less color Doppler, because if the color Doppler increasing with solid one, it will be ORADS 5. Next, please. Then we will go to the higher percentage of, or the higher percent of getting a malignancy, more than 50%, which is ORADS 5. ORADS 5 here, we can see if there is more number of papillary projection, more than 4, of any size, of any color flow. So papillary projection, increased papillary projection with a lot of number. This means going to malignancy rather than going to benign lesion. If we have a multilocular cyst with solid component of any size, but with high stage or high grade of color score, this is usually going to malignancy rather than to benign. So if you can see here, the solid component more than 80%, but with color flow number 4. So this means there is increasing chances of getting malignancy as well. Next, please. And then if we have more than 80% of the solid component with irregular contour, it's another feature of getting more chances of malignancy. And of course, if you have ascites or peritoneal nodules, so it's a whole market that can suggesting more or less a malignant transformation rather than benign one. Next, please. And from these categories of ORADS 1, 2, 3, up to 5, we can taking the line of management, whether it's a conservative or it can be taken in a general gynecology units or in a gynecological oncology units. So usually ORADS 5, ORADS 4 needs gynecological oncology units. ORADS 3 maybe in the general gynecology units. ORADS 1 and 2, it usually saying that we will need only for conservative treatment. There is nothing extra. And if we see what is the similar for this one, for the O-RAD system on the IOTA or in the ADNEX model, you can see here that the ADNEX model, the risk of malignancy index and the ADNEX model can also eliminate some of them. And then the risk of malignancy index from 10 to 50% will like the O-RADS 4, and the other will be more than 50%. So I mean, you have 3 tools now. You can use whatever you like, but the more comprehensive one is the O-RADS one, because it gives you the idea how to manage and how to go. And at the same time, if you say to me it's O-RAD 3, so directly it get to my mind that this one is a low risk group and it can be managed in a general gynecology units and so on. So I mean, this is a more standardized system of this one. And the likely one I will give you by the end of this presentation also, one of the applications that you can use that summarize all of that O-RAD system on your phone. So it will be very simple actually to describe and getting all the information about that one. Next, please. So now this is for the ovary, and then if we can see from the start that we have the ovary and then the fallopian tube and this constituting the adnexia. So we need to know if there is any pathologies in the fallopian tube that can be seen with the ultrasound or not. So normally in the normal fallopian tube, it's not commonly identified in the normal situation, except if there is a pathology or there is abnormality. If there is a mass or there is something inside. Something inside means it may be some of the fluid or maybe distension of the structural tube itself. So next, please. Hydrosalpinx is the one that we need to put highlight on it, because usually it's found in many of the patients, especially after recurrent attack of salpingitis and salpingophritis and so on. So how we can see it in the ultrasound? Next, please. Yeah, this is a picture, how we can see it. So this is the ovary, this is the tube. That tube is distended here, as you can see, and this is on the ultrasound. This is the ovary highlighted by the one with the blue, and this is a tube highlighted by the orange one. It's here. So it's distended tube because the tube now is containing fluid inside. So this is a hydrosalpinx. Next, please. And this is a hydrosalpinx again, if we put some of the color Doppler inside, because it may contain some of the vessels outside. Next, please. It can be markedly distended like that, and you can imagine it's a follicle. No, it's not a follicle. That's why you should identify the ovary very well. And whatever the other structure, what is the origin of that structure? It may be from the fallopian tube. So it's very important not to see a structure like that and saying it's a follicle or a cyst because it's a large one. No, it's a fallopian tube. Next, please. And this is the most pathognomonic or the most characteristic features that you can see. If you see this one, this is typically a hydrosalpinx sign for the ultrasound itself. It is not actually all the time. It's not all the time you can see this finding, but you are lucky if you see this finding because it's a diagnostic finding for the hydrosalpinx per se. And by the way, the diagnosis of hydrosalpinx generally is done by the ultrasound, not by the hysterosalpingography, because it's a common mistakes that the people coming into it actually. But it is by the ultrasound because it's a persistent. It's not like a pooling inside and then it will go away and release. No, it's a fixed one. So it's usually by the ultrasound diagnosis. Next, please. Another one. Can you imagine here? This is another one, and this is a tube loculated on the two sides here, and you can measure this one like a follicle. It's not a follicle, it's a fallopian tube. Next, please. By the 3D, it can be more evident. You can see here the tube, how it come, and how it can be like separated like a two follicle like this. So it's very important to take in your mind that the ovary is not alone, and the ovary has the fallopian tube beside, and the fallopian tube may have hydrosalpinx that may resemble the follicle itself. Next, please. Next, please. Another important point is the adnexal torsion. Adnexal torsion, you should have in your mind that there is adnexal torsion that can happen, and this adnexal torsion. So if you have it in your mind, you will diagnose it, because the adnexia here, especially the ovary itself, will rotate around itself. So next, please. How you can diagnose it? Very important. Usually, it's more common in the adolescent girls, especially in the girls of the athletic girls, and the girls that doing a lot of activities, sports, and so on. And the main diagnostic criteria will be by the ultrasound, whether with color flow Doppler or without a color flow Doppler. You can diagnose it very well. And what is important in the diagnosis, it's a spot diagnosis. Suspicion is very important. And if there is suspicion and you have the signs with the ultrasound, you should immediately deal with that condition with a prompt surgery or refer it for surgery, because at that you may destroy or you may lose actually the ovary and the adnexia at that time of the very young girl. In this picture, if you can see here, and you will lose all the whole ovary, as you can see. Next, please. And this is how you can see it on the ultrasound. You can see here that the follicle, because there will be this twisting, will leading to closure of the blood vessel, and then there will be edema. So there will be shifting of some of the follicle to the periphery. Some of the edema will appear on the periphery of the uterus itself. The blood vessel will be bizarre and will be decreasing. So it's a lot of signs, but it's not important to see all the picture like that. But it's acute abdomen in a suspected young girl, maybe of course maybe an old one, but I mean it's more common in the young girls. But you can see it on the patient when they have, like as an example, corpus hemorrhagicum, maybe something like that, because it have a heavy weight for the ovaries, who can be twisted very well. Also, if you have like an abnormality in the ligament itself, in the ovarian ligaments, maybe also in the cases of dermoids, which is very common in that, maybe also. So what is important here is to think that a torsion is present. Next, please. You can see here more evidence with a twisted adnexal. This is a real case we have on 23 years old, and the ovary is enlarged here, edema, multiple small follicles are visible on its periphery, and you can see here the edema on the left side, as you can see. Next, please. You can see here, there is no blood inside, the blood from the periphery, because it's already occluded by twisting of the ovary around its axial one. Next, please. You can see here, this is an actual case also, and this is a laparoscopic feature of that one. So you can see the twisting of the pedicle itself with more edema, and then the occlusion of the vein firstly, and then the occlusion of the artery will be later. Next, please. Another picture. Next. And these are features we said about it, how the torsion is can be completed until no arterial wave form can be detected. This is another one. Next, please. Next, please. Next. Yes. Another entity. So no, the previous one. The previous one, yeah. So another one, if you are lucky, that you can see the twisted pedicle, which is a very specific of the ovarian torsion, but don't search about it. I mean, if it is present, okay, don't search about it, because you have a lot of signs that can diagnose your case, and immediate intervention is very, very important. Next, please. Yes, the coming couple of slides will be about special group, like the adnexal mass in the special in the pediatric age group. What is important here is that mostly of the pediatric adnexal masses is usually malignancy. So it's very important, and be very cautious with dealing with this age group, specifically with the possibility of torsion is very high. Next. The other special group, which is a pregnant woman. Pregnant woman is an adnexal masses and is a dermoid cyst. Cancer ovary is very rare here, but usually the ultrasound is a very diagnostic tool. The tumor marker, according to what you are seeing in your ultrasound and what is the overall clinical aspect of the situation, because sometimes this may be the first time for the female to be examined by the ultrasound, and you find this is a dermoid cyst or a cyst with any changes. So please go ahead again and go back to your O-RADS, whether it is 1, 2, 3, 4, 5, and manage accordingly, whatever she's pregnant or not. But this is very important because you will find here maybe the anatomical structure will be more different. Next, please. So before going to the take-home message, which is 3 or 4 take-home messages, I would invite all of you to go to the application. After we finish this webinar, you can go to the application of the American Radiology, and they have an application for the O-RADS implementation. I can send you the application name. So it's for the American Radiology Society and American Radiology College, and they have a application. You can download it in the iPhone or the Android, and you will find it very simple because you will put in it whatever the pictures you are seeing. So it will ask you whether the size, whether the papillaries, whether septations, the blood color flow, and so on. And by the end will be the O-RADS number. So you will have like O-RADS 1, 2, 3, 4 according to the situation. So you are not so much minded with the remembering all the criteria for every O-RADS one. So I will send all of you these as well. So the take-home messages will be: the ultrasound is a very useful tool for you, can recognize the normal and the most common abnormality on the adnexia, and especially on the ovary and the ovarian cyst. Don't forget your clinical sense, very, very important. Image is not everything. Be ectopic-minded, be torsion-minded, because these two things usually missed because we are not putting them in our mind. Be suspicious about the bilaterality and the other features of malignancy to screen, not to diagnose. Very important. Bilaterality, the vascularity, the size, the papillary formations, all of that is a very important sign for suspicion of malignancy. Next, please. The IOTA simple rule and the adnexal system have a good predictive value, however, may need expert ultrasound examination and didn't provide a management plan. On the other hand, O-RADS ultrasound system have a good diagnostic performance in classifying the adnexal mass, establishing the risk stratification algorithm, and management plan. So please try to use it. I think it's a very simple one. It's a very productive and give you the whole idea about how you can manage your ovarian cyst and ovarian masses as well. Next, please. And thank you very much. And as I am always saying, that every ending is really just a new beginning. So this is a beginning of your question and answer. Thank you so much.
Thank you so much, Dr. Galal. This has been such a wonderful presentation. We do have a quiz, a small quiz for you guys, and then we'll go into the Q&A. The first quiz should be on your screen now. Feel free to answer the first question. and we'll go into some additional quizzes with pictures in a couple of seconds. So take your time, answer those questions that you see on the screen. I see a lot of you are answering, about 20% of people who are here with us right now. So if you have any questions, feel free to submit them to the Q&A box, and we'll get to them once we finish with the quiz. Right. I'll give you another 15 seconds for the first question. All right, let's see. Here are the results. The correct answer is Doppler assessment. Dr. Galal, would you like to comment on the result? Because I think we had some people who put serum CA 125 level, which is incorrect, but would you like to comment on that, why people may want to choose that one?
I think the majority choose the Doppler, but is that right?
The majority, which is 44%, chose serum CA 125 level.
Already?
And then Doppler comes next.
Yeah, okay. Okay, but as we see it very clear that I think there is a mix between the risk of malignancy index and the ADNEX model. Maybe this is because C 125 is a major component of the risk of malignancy index, but in the ADNEX it's not the major component. And it's not excluded here. So the exclusion here is a one of the Doppler ultrasound only.
Thank you. All right, and I'll share another question. I will leave this open, and then we'll also share another quiz with questions. So you should see on your screen, feel free to put it in the chat. So on the screen, you have some questions with pictures, and feel free to put 1, 2, or 3. If you have. I'll give everyone maybe another 15 seconds. Feel free to post it in the chat what your answers are. All right, Dr. Galal, what would be the correct answer here?
So most of them saying benign. I agree with them. Congratulations. These are benign lesions, yes. So without the presence of malignant lesion, it's okay. It's a benign one.
Right, and this is another one for you guys. So feel free to give an answer, left or right. I'm sorry, not left or right. What is the what would be the options for this? You want everyone to chat.
So let us say for the left one, what is the O-RADS for this one? And for the right one, what is the O-RADS for the right one?
Right. So we put left and then right.
Yes. So for the left, no, I'm not saying benign or malignancy. I'm saying the O-RADS 1, 2, 3, 4, 5.
great engagement. I'm seeing a lot of people are commenting.
Yes.
All right. Would you like to share the results, Dr. Galal?
Yes, I'm just going to the results for them because there is a lot of variation. So for the left one, most of them agreed that it is a 5 or 4, right? So the actual one for the left one is 4 because the blood flow here is considered color flow Doppler number 3. So it's a large mass, and these large cysts multilocular with the color flow here is considered 3. So this is considered O-RADS 4. O-RADS 5 will contain a lot of blood vessels inside also, so there will be a lot of vasculature here. For here, which is this one, this most of them saying it's a 2. The difference between 2, I will consider it 3. The difference between 2 and 3 here is the size. And this size is more than 10 millimeter because it containing most of the screen here. So it's a larger one. Because it's a larger one, lower blood fluids consider number 1, multilocular, so it's 3. So it's not 2. 2 means it's a small size of the cyst itself. So it's here considered 2. Of course, there is one person saying it's O-RADS 1. O-RADS 1 is not like that. We said O-RADS 1 means a follicle or a corpus luteum. Otherwise, it's not. So ignore O-RADS 1 because it's a physiological item. It's not a pathological one. Okay?
Thank you. Great discussion. Let's go into the Q&A. We still have some time, so about 6 minutes for your questions. I think we have one question submitted. How can one differentiate hydrosalpinx from dominant follicle in the picture?
Okay, a good question. I think this was for the picture that containing 2 of the hydrosalpinx separated. The tricky point in the ultrasound usage of the vaginal ultrasound is to rotate you know that you have from 4 to 6 movement of the vaginal probe. The very important is to rotate itself. So getting it in many dimensions, it may be vertical, maybe transverse, and so on. If it is like the tube, it will be elongated by this movement. If it is a follicle, it would not be affected by this movement. It will be the same diameter as it is. The same applied for the internal iliac itself, because internal iliac usually sometimes resembling the follicle, because if you take it like a cut screen of it, this cut screen will be rounded. So it's the same, and some people facing some difficulty, especially for the ovum pickup and so on. So whatever the structure you have, screen it in more than one direction. This will give you the better answer. Okay.
Great. Thank you. The second question, what is the most common predisposing factor for torsion?
Okay, let us say maybe 2 aspects will be the heaviness of the ovary itself, if it's containing a cyst or a corpus luteum or something like that, and the vigorous movement. That's why we see it in the fact in the people like the sports, because there is a lot of activity, vigorous activity all through. So vigorous activity or some of the activity, and at the same time, if the weight of the ovary is heavier, and if there is elongation, this elongation you will not detect actually until you are doing the laparoscopy itself. Okay.
And I see one more question in the, I guess, directly was messaged to us. What do we do in pelvic congestion syndrome? How common is it?
What is the question, please? Because I have another one here. Okay.
What do we do in pelvic congestion syndrome? How common is it?
Okay, this is another entity, of course. But what we can do, we have two entities for the pelvic congestion syndrome. We have the one primary and the one secondary. The secondary, of course, it deal with the cause, whatever this cause may be, endometriosis, maybe fibroids, maybe other things, maybe infections, or and so on. So deal with whatever the situation is. For the primary one, it will depend upon many things, but the main entity will be to support the vein itself, so it will not be congested so more. You are dealing with it like that one of the varicose vein itself, because usually the etiology is the same, but it's a big topic. So this is the simplest way to have like a support for the vein itself, so it can decreasing the pain to some extent.
Thank you. Another question, what is the difference between a solid component and a papillary projection? How can you differentiate between small papillary projection and small solid component?
It doesn't matter if it is a small, it's a papillary projection or a solid, it's still the same, because the papillary projection is usually solid component, so it's not a problem at all. But the papillary projection is usually coming from the wall itself inside a cyst. So it's a whole cyst and containing some of the projection like that, and the size will be different. But in the solid component, there is a large mass, a bigger mass. And as we see it in the presentation, it can be more towards 80% or more than 80%. So this is a solid mass structure, but the papillary is a smaller one all over the wall.
Thank you. And then we can share the application
Yes.
that Dr. Galal was talking about in the follow-up email. So we'll send you a link. And this was recorded as well. So you should be able to rewatch the presentation. It will be ready by next week. So you receive an email with instructions on how to access the recording. And we can definitely follow up with any questions you have. But as of now, I think this were all of the questions. So thank you again, everyone, for joining the webinar. And thank you, Dr. Galal, for taking the time to present with us. We'll hope to see you soon, maybe with other topics covered. But thank you, everyone. Feel free to answer the learning questions that you see on the screen. We collect a lot of feedback to see what are your interests and if you enjoyed this presentation. And this helps to plan further webinars for us. But thank you again. We'll see you next time.
Thank you so much. Thank you for everyone attending.